So welcome everybody online. I know we've got, it looks like the team rooms here, so 8 people online, but a few more probably in the halls. Thank you for taking the time out to come to this presentation today. This is a sort of special ICU, joint ICU cardiology and maybe cardiac surgery rounds. And we are excited to welcome Dr. Zach Singer as well as Dr. Mike Ward from the Division of Cardiology here at LHSC and Western. Dr. Singer is a PGY6 in cardiology, who was just telling us it's been a couple of years. This has been his passion project, or one of his passion projects, to try and discuss a shock team at LHSC. And we are excited to welcome him into our training program next year. So he is an incoming ICU senior resident. And Dr. Ward is a cardiologist here. He's an interventional cardiologist. Who's chosen to also be part of the critical care Western family by choice. So we welcome him at our barbecues and look forward to the collaboration. And I'll let these two sort of gents explain what this program is. But over the last several months to years, there's been an awareness that multidisciplinary management of the most sick patients with cardiogenic shock and consideration of procedures and machinery, as well as monitoring strategies, does really benefit from multidisciplinary approaches, and how to actually systematize that, the logistics of how to implement that, why this is true is sort of what they're going to speak to today. So I will turn over the microphone to my colleagues from cardiology, and thank you both for joining us.
Thank you very much, Paul, for that very nice introduction. And yes, it's lovely to be part of the ICU family in more ways than one. What Zach and I really wanted to talk about today has evolved over the last couple of years. Bringing a cardiogenic shock team to LHSC has always been something that was on my bucket list of to-do items when I joined. And as you accurately said, Zach is very passionate about this. And so we've been working on this protocol for 2 years. I'm very proud to say that over the 2 years, it changed from just an idea and a proposal to now something that we're very close to being ready to roll out. There's just a few, and we'll get into the details of little things that we need to sort out. But it really is, I hope that this talk will serve as really an introduction to the program that is starting imminently. And of course, is meant to be multidisciplinary and fully collaborative, which is a great addition to, I think, our group. So I will figure out how to go to the next slide. So our objectives today for the talk is really just to talk about the rationale of cardiogenic shock teams. We will go through some of the data on shock teams internationally that have shown a benefit, and also talk about the pros and cons of them. We'd like to use a few key examples in Canada, because I think, of course, the Canadian experience is especially relevant. And then talk about our proposed framework for how it could work in London. We call it the London Regional Cardiogenic Shock Team because just like we are a spoken hub for various of the services we offer at LHSC, we'd like to see the shock team as eventually being that, but I think it has to just start as a smaller enterprise at first. And hopefully they'll have lots of room for discussion as well. So as all of you know, we don't need to teach you what cardiogenic shock is, but obviously, as you said, it's our sickest patients. Cardiogenic shock mortalities vary between 40 and 55%. In acute MI, which is about 30% of causes of cardiogenic shock, is very severe, and obviously intervention is important. But there's also acute decompensated heart failure for people with chronic heart failure. We'll talk a little bit about the data on revascularization of infarct-related artery, and when it is important to bring people straight to the cath lab and when it's not. And then also talk about shock teams and how they're rapidly gaining attention. So on that note, I'll pass it over to Zach to continue with our background.
So this is not news to anybody, but there are many different etiologies of cardiogenic shock. Several of them are listed here, and this is important, relative to the prognosis of some of these different things and treatment strategies. So I think we can move beyond this just to recognize that it's not a monolith, and there are different scenarios that we deal with. And again, this is very much review for the crowd, but the pathophysiology of cardiogenic shock is really, four main systemic insults. One is a systemic inflammatory syndrome that occurs, and these are all interrelated. It's not a progression of one causes the other. But there's a systemic inflammatory syndrome. There's ischemia of both the myocardium, but also of the end organs. There's compensatory vasoconstriction that occurs as a means of trying to maintain organ perfusion, but eventually or in some specific subsets of patients that can be overwhelmed and end up with a vasodilatory phenotype. And then, of course, there's volume overload. And so these are different things that we try to modify when treating patients, but it's important to recognize that these are kind of the domains of the systemic insults. So the four kind of classical hemodynamic phenotypes that have been taught for this, really three are cardiogenic shock and one is shock, but not of a cardiogenic etiology. So there's classic cardiogenic shock, probably the easiest to manage, which is low index, high SVR, high wedge. So after load reduction and volume removal really is the mainstay, plus or minus inotropy as needed depending on the blood pressure. Dry patients, those who have a low index with a high SVR that's compensatory, but whose wedge pressures are not very high. These probably scare us the most because there isn't a lot you could do. To stabilize them, you often need to consider advanced therapies. So MCS, either on a temporary or durable basis, and long-term VAD or transplant, because you really optimize the hemodynamics as best you can. And so in terms of exit strategy, this is a challenging population. And then the very as of yet kind of difficult to understand and manage the vasodilatory type. These people probably have the worst prognosis, whereby the index is low, they're congested, but now the SVR is low or inappropriately normal. And there are many different strategies proposed for how to deal with this, but really we don't know how to treat these people properly. And then finally, of course, vasodilatory shock, which is not in fact cardiogenic. So this is how I think is worth thinking about these patients just in kind of three different axes. So one, of course, is the shock severity, which is the most immediate pressing concern when you're resuscitating the patient. How sick are they and what intensity of resuscitation do they need? But I think just stepping back and having a little bit of a bigger picture approach is really important when we think about how to deal with these patients beyond just the initial resuscitation. So, if you are thinking about whether they need a type of MCS therapy, what is the exit strategy? What is the prognosis? And so we look at things like the phenotype of the shock, which can be assessed via invasive hemodynamics classically, although you could certainly gather useful information without an invasive approach. And then, of course, there are risk modifiers that are highly relevant to prognosis. So modifiers being presentation with cardiac arrest, significant frailty, comorbidity burden, and these things really changed how we approach the management of these patients. So I think for those who are not as familiar with this classification or don't quite have it at the tip, of their tongue, it being something that you deal with frequently, this is very useful to be aware of. I think this is our common lingo, our language that we use to communicate with one another about what this patient looks like, how sick they are, and where we see them going. And it helps people understand the acuity of the presentation, as well as kind of conceptualizing the patient's level of compensation and response to therapies. So I think it's really important that all of us become familiar with this language because this is the language of the field. And so, there's the ABCDE classification. Thankfully, they all help remind us what's what. So A is at risk. This is not relevant to the ICU. B is beginning shock. This is often under-recognized, but this is a patient who's hypotensive or, tachycardic in the context that it being due to a low kind of cardiac output state, but is not yet hypoperfused. This is the patient who's at risk and has no reserve and can get into trouble with incorrect management strategies, but is a patient whom you can, prevent from degenerating into shock. C is the classic cardiogenic shock that we're all familiar with. They require some sort of intervention to maintain perfusion, whether it be an inotrope or a device. D is a patient who's deteriorating. So despite initial management, they're getting worse. They're not restoring normal perfusion. There are other kind of things that can get you into category D, like multiple devices, for instance, and that's not as relevant for now. And then E is extremis. This is a patient for whom if we don't do something right now, they will die, and they need immediate attention. And so I think having this is good because it can just kind of help us all discuss with one another what we're really dealing with when we're describing a patient. Is this a patient who's a B that you're worried about, but you probably have a few hours to sort out, or is this a D and getting worse? That helps. And the extension of that is that these categories are not immutable, so patients can move up or down the categories according to how they're responding to treatment. So if they presented as a D, but with a single inotrope, they're now in a C, or perhaps they resolve the hypoperfusion and they're kind of like, now their perfusion's normalized and you can wean the inotrope off, so then they go down to a B. So this kind of helps you understand how they move through the categories and how they're responding to treatment. It's very dynamic.
So with that, the question comes up is what is the benefit of having a formal group that focuses on cardiogenic shock? And so the concept is like a lot of other multidisciplinary teams in various other conditions, but really the key of having a focal group on cardiogenic shock is to really have dedicated training and experience to increase the rate of recognition, make some early decisions about management, and specifically to cardiogenic shock is when to escalate care apart from just medical therapy or procedure, and actually when do you start thinking about devices. So these are very subspecialized devices and require, formal focus on it. Just like other teams in hospitals, like the trauma team, STEMI team, stroke team, expert teams are the standard, and they have been proven to increase efficacy and outcomes. And so why not do this for our sickest patients? And we'll get into some of the more specific examples, but when you look at centers who have invoked a shock team, there is improved survival. So it's not earth-shattering with only a 5% overall improvement in survival, in hospital survival, but there's also some other sort of, I guess, softer indices of benefit with length of stay, readmissions, and also just general hemodynamic states. There are certain patterns where high volume centers that focus on cardiogenic shock will have higher rates of early revascularization if that's needed, higher rates of mechanical circulatory support devices, even just as simply as balloon pumps. And these high volume centers are associated with better survival, Detroit being one of the leading centers in this in North America. So the general approach, and we'll come back to this in various ways, but overall, the approach of these teams is that when cardiogenic shock is suspected in an individual, so it's usually in the ICU or the CCU or in the emergency room, then immediately the shock team is activated. Now, how that's done in different centers is slightly different, but overall, it requires a specialist of one of at least 4, and mostly 5 departments of the hospital. So critical care, heart failure or advanced heart failure, interventional cardiology, cardiac surgery, and sometimes specialist in ECMO services if that's available at that center. And there's usually a phone call or some pattern of desynchronous or synchronous, or I should say, collaboration and connection. So sometimes it's through a web-based app like Teams, and sometimes it's just on a phone call through a pager. But what essentially that's meant to do is connect all the people that are going to have a strong opinion on this area and be able to make the decisions and say, open up the cath lab or start an MCS device promptly and efficiently. And then if there's other diagnoses to be considered, then those can be done kind of on a concurrent manner. So while the initial phone call is critical, there's also follow-up and rounding and stuff in the wards or in the ICU by the shock team, apart from just the regular MRP that's taking care of that patient. So it continues to be a collaborative effort. So not surprisingly, these centers that work this way have higher use of invasive hemodynamics, such as use of PA catheters. They use advanced circulatory support devices more often. Less balloon pumps, in fact, probably because they have access to the higher level MCS, and lower levels of inotrope, and certainly less time using inotropes only because the action is usually taken for the next step a little bit faster. And overall, if we look at just the cardiac intensive care units, there's a trend toward lower mortality in the centers that have these teams. I want to really stress this slide here, and it's a bit busy on the right, but it's a topic that often comes up in managing these patients is what is really the importance of hemodynamic assessment? And by that, I mean Swan-Ganz catheters and, serial measurements of cardiac output and other indices. Now, obviously, we're living in a landscape post a couple big trials that did not show major mortality benefit of using Swan-Ganz catheters in the ICU. The ESCAPE study looking at patients in heart failure, and also the often quoted Pac-Man study that looked at routine use of PA catheters in the ICU. I just want to note that these patients that we're talking about in shock team weren't really in these trials. So ESCAPE did not recruit patients in cardiogenic shock, and Pac-Man only had 11% who were actually in cardiogenic shock. And what I think, we are stressing, and I think, and we're not the only ones, I think the shock teams in general are stressing, is that invasive hemodynamics aid in our care of these highly sick patients and do improve outcomes. So just looking at this slide, if you look at a retrospective study of 8 US centers that have shock teams, they looked back at over 1,400 patients and saw what the outcomes were, and kind of stratified them according to what level of hemodynamic assessment they had when they were in cardiogenic shock. So those 18% had no invasive hemodynamics, 40% had incomplete. So, they didn't have necessarily all of the hemodynamics done, and 42% had full hemodynamic assessment with Swan-Ganz catheter on a repeated level. And you can see, if you look at their mortality levels in the bottom right levels, especially in the sicker patients in stage D and stage E of cardiogenic shock, there was a notable improvement in the mortality if full comprehensive hemodynamic assessment was done during their care. So that, there's not a lot of data on this, but this is, I think, pretty compelling. So then I think it really does show that there are certain benefits of having a comprehensive assessment of these patients. Like I mentioned, early detection is a good thing, but also invasive and well-informed decision-making in these patients does make a difference in how they're doing. We're going to spend a little bit of time talking also about what are the different cardiopulmonary support devices that we have and here at LHSC, but in general as well, and what the benefits of those are. And also the follow-up of a shock team really is helpful in deciding when to wean these mechanical circulatory support devices, because not many people know how to do this, and having a concerted experience and reaching out to colleagues across the country is going to be helpful.
Yeah, and for that matter, I'm not sure there's any such thing as an expert on weaning MCS. It's an active debate. There's articles published all the time on people's various approaches.
Yeah, exactly. But I mean, I think every center kind of develops a system that works for them, which is, again, about, informing ourselves about the quality of our care. I don't want to belabor this point too much, I mean, except for the fact that there is evidence for early invasive care in cardiogenic shock that's secondary to an acute MI. Often we have debates over, is this ECG bad enough to send them straight to the cath lab? Is this patient stable enough to go straight to the cath lab? Obviously, each patient's assessment is different, but centers who have, triaged people for urgent revascularization have done better for patients who are already in cardiogenic shock, especially in the elderly population where there's the most benefit to be had, because these patients have the worst mortality in that category. The other study I think is important to discuss is the culprit shock study. This looked at 700 patients who were randomized to culprit lesion only PCI versus complete revascularization, so multi-vessel PCI essentially. And it was a bit surprising when this came out that actually the patients who only had the culprit-related artery. So, for example, the large anterior STEMI, you only do the LAD, and even though there's residual disease in the circumflex or the right coronary, you don't actually address that in the initial presentation. Those patients actually did better. They had a better mortality outcome, reduced death from any cause, and also reduced rate of renal replacement therapy. And the discussion about why that was probably because there was less, so the procedure itself in the cath lab was deemed less complicated. So there was less contrast use. There was unfortunately higher use of Impella, which is one of the MCSs, because of presumed complexity. We don't know. It's a trial. They didn't report on exactly why it was chosen to be put in, but presumably because of a deteriorating clinical status. And I think, taking care of these patients myself in the cath lab, I have to admit that sometimes you want to get them to the CCU or the ICU where their hemodynamics will be addressed more so than we do it in the cath lab, quite frankly. So sometimes you just fix the culprit, and then what actually helps in their recovery is the early hemodynamic addressment. And I think the corollary to that is what we all know in the cardiology spectrum, that the more time we wait for acute myocardial infarction treatment, the worse people do, which is why we have STEMI programs and rapid response programs for acute MI. So, Zach, do you want to take over from here?
Sure, thanks. So in general, the goals of using these temporary MCS devices in shock is there's a few scenarios, but in general, the first thing is to support end organ function. And then there's a few pathways the patient can be on. So they could be on a bridge to recovery, which is always best case scenario, but often is wishful thinking, depending on how sick they are. Sometimes it's just an immediate stabilization maneuver to get them to revascularization, definitive revascularization, or mechanical repair with their surgical colleagues. And then sometimes it's bridge to a decision, whether they're a candidate for advanced heart failure therapies, or bridge to the definitive treatment itself, durable LVAD or transplant. So there are various support devices available, and we could focus on the ones that we have at LHSC because that's most relevant at the moment. Everyone's quite familiar with the balloon pump and should be very well familiar with VA ECMO. So we don't need to discuss that too much further at the moment. We do have other devices which we'll present on other slides, and importantly, there are some efforts occurring to try to obtain access to Impella devices at LHSC as well. It's quite early stages, and it will not be something available within the context of the shock team at its onset, but certainly may become a tool available in the future. So it is a device that's important to be familiar with, and certainly we'll develop more institutional expertise with this in the coming months to years. Centromags are our most substantial form of temporary MCS support that is not an ECMO, and has very significant differences vis-a-vis ECMO with respect to its hemodynamic impacts. Centromags, by their nature, are devices that vent as well as provide support, whereas ECMOs increase afterload and risk the heart becoming progressively ischemic and distended and so on. So they're quite different conceptually in what they do. But centromags are surgical implants, so the patient needs to be able to tolerate, in most cases, a sternotomy. In all cases, a sternotomy to implant this device. So it is a big undertaking just to get them through the initial stabilization with the MCS alone. There's different configurations. You can have LV support where it drains the left atrium and flows out to the aorta. You can have right-sided support where it drains the right atrium and flows to the PA, or you can have biventricular support with two of these devices connected, supporting both sides of the heart. The pump sits outside the patient, and it's got a magnetically levitated rotor, so there's better hemocompatibility between the blood and the pump because of decreased contact with the bearings that rotate, so less hemolysis, less clot predisposition, etc. These are good for weeks. You could support someone on a centromag for weeks, but this is not something you could do for months. So days to weeks is the idea with these devices. So, balloon pumps are the most straightforward device for us to access. And they do have a role, but it is important to recognize their limitations. So there was the most important trial, the IBP Shock 2 trial, randomized 600 patients in acute MI shock, so not decompensated heart failure, very different populations. I guess that would be another kind of pearl of this discussion today, is that acute MI shock and chronic decompensated heart failure shock are two very different beasts, and the patients are very different, and the approaches are conceptually a little different. So we always need to recognize what scenario we're in and what the evidence teaches us about that scenario. So for acute MI shock, balloon pumps have been demonstrated to not offer any benefit in all comers. Doesn't mean there aren't individual patients that could benefit, and I think that's where the value of a shock team can come into play, is discussing such cases. But overall, this is not generally felt to be a useful intervention. Different jurisdictions have interpreted this data differently. So in Germany, for instance, I know that balloon pumps are not available in the hospital. They consider them class 3, harmful. Whereas in Canada, it's by far the most commonly used MCS device. So, the exact same data is interpreted quite differently in different contexts. And so that's why the focus of teams can be quite helpful. Now, that being said, in decompensated heart failure shock, balloon pumps actually do have a signal that they might be quite helpful. And totally anecdotally, in discussing with my staff and our advanced heart failure teams, there is a feeling that this could be a true signal. That in decompensated heart failure shock, often those patients are wet with high SVRs. They're chronically clamped down, and that's a patient who might actually do very well with a balloon pump in terms of alleviating that SVR. Whereas in acute MI shock, there's different factors at play. There's the acute inflammation. There's often some component of vasodilation. There's poor cardiac reserve because of the MI itself. So there's not as much recruitable myocardium because it's stunned or ischemic or infarcted. So these are just kind of different scenarios. But balloon pumps certainly can still have a role in some cases, and I think that's important to highlight. I mean, I don't want to spend a lot of time on this because I think the bottom line is that there is no evidence for the safety or efficacy of Impellas in cardiogenic shock that is compelling. It's also important to recognize, however, that the evidence that we have is totally limited in its scope and is not definitive in that Impellas, are not at all useful. In general, what the evidence shows us is that there's an increased risk of complications using Impellas. Many different kinds, primarily vascular access related, as well as bleeding. Mortality tends to be similar in all of the very small RCTs that we have available with this device. The biggest one is this IMPRESS trial, 50 patients, but probably just too sick, not salvageable. 90% cardiac arrest, lactates of 8 on presentation. Most died from neurological death. And so it doesn't really help us know too much about whether Impellas do or don't have a role, but it does teach us about their safety. And most importantly, the Danger Shock trial is reporting at ACC in a month. This is a Danish-German collaboration, randomizing, I think, 300 or 400 patients to Impellas in acute MI cardiogenic shock, who, patients like these IMPRESS patients were excluded. So I believe cardiac arrest is an exclusion. But that trial will, I think, be the best evidence by far about what the role, if any, is for Impellas in this context. So I think very, very soon we'll have actually some excellent data, and I'm sure this will be coming to a journal club near you in the next few months. So, this study just kind of looked at an observational data set. They took a larger number of Impella patients. Some of these patients were using 2.5s, the original Impella, which we don't use anymore anywhere. It's not felt to be enough hemodynamic support. CPs are really the minimum that are considered. But it took a few hundred of these. It matched them to the IBP2 shock patients who, were randomized patients who did not, of course, get Impellas because that was a balloon pump trial. And, in this analysis as well, no difference for mortality and more complications with the Impella. So no new information.
Okay, thanks, Zach. Yeah, I mean, I think also to what you alluded to, with the evidence around the Impella, it really has become kind of the standard of care. It's not a gold standard because we don't have the evidence to prove it, but when you look at shock teams across North America and also in Europe, the Impella is used as a rapid access very effective way of stabilizing hemodynamics in cardiogenic shock. Not necessarily long term. It doesn't have the longevity that other MCS devices do, but it's still something that's very helpful in the early management of these patients. And so there won't be better data because no one is really generating that much in term except for the danger study. So, we have to kind of use experience in centers also to indicate when is best to use it rather than look straight at the data.
Absolutely.
So I wanted to talk a little bit about what data we have on cardiogenic shock teams. The first real kind of academically driven team was the National Cardiogenic Shock Initiative, really that was pioneered in Detroit. And really what they were doing is they were doing a multi-center prospective single-arm study and basically treating patients who had MI-related cardiogenic shock with Impella prior to even going to the cath lab. And so this was, a study of early invasive hemodynamic support for patients. And, they defined shock as having an EDP greater than 15, so end diastolic pressure, which we measure in the cath lab at the time of the angiogram, and also a cardiac index less than 2.2. And all these patients then got an Impella prior to doing any invasive work on their coronaries. Now, this actually has spurred quite a few studies down the line of actually maybe even the potential of delaying STEMI, but that's outside the scope of this, PCI, but that's out of the scope of this discussion. But essentially, having the Impella in also indicated how to change ongoing therapy of the cardiogenic shock. So if the cardiac power output was high, and the PAPI, which is, we'll get to that, it's a marker of contractility of the RV. If those were both good, then it indicated that, we could wean inotropes and vasopressors, and having the swan there to indicate that was very helpful. And then also having the swan there to see, okay, is it just LV shock? And therefore we need to escalate LV support, or is there a component of RV failure as well, which is where it gets a little bit trickier because often these devices are only supporting the left ventricle. The Impella itself has a left-sided form and also a right-sided form. So there is an R Impella, which is meant to support the right ventricle. So that would be assessed also by continuous monitoring with the Swan GANs. So, in this also, this group also showed the first real model of an independent shock team rounding daily in the ICU on all these patients to help in the management that obviously the MRP team is doing already very well most of the time.
I think what we just haven't said explicitly, but is worth just mentioning, is that there's a hypothesis that inotropes and pressors are inherently deleterious to the heart in the setting of cardiogenic shock. It remains to be proven, I think, definitively, but that's part of the rationale for a lot of these protocols as you see them presented, is that, minimizing exposure to inotropes and vasopressors may be a useful goal of management of these patients beyond just immediately stabilizing the patient. We all do this anyway. We try to minimize the amount of support we provide and wean as quickly as possible, but having the invasive hemodynamics may allow us to do that even more aggressively than we might otherwise.
Yeah, and so they reported essentially the results of their retrospective study, or it's actually prospective, where they actually reported a survival to discharge of 71%, which is quite excellent. Now, of course, there was all MI related, so those patients tend to do a little bit better than the decompensated heart failure patients, but still, it's a very good outcome. And, they reported that their overall use of right heart catheterizations during the admission were at 93%. So, again, we have to put this data together as observation of what a system approach is doing. It's not necessarily that just the right heart cath measurements is improving mortality, but it's honestly the cooperative efforts from everyone involved to address what we know about the patient and respond accordingly and efficiently. And having tools like the right heart cath is obviously just part of that approach. Other groups have published their outcomes since starting their cardiogenic shock team. So obviously the panel the data I just showed you is in the top left panel. There's another center in northeastern US, the Inova Heart and Vascular Center, that showed a improvement in their 30-day survival after starting the shock team in these cardiogenic shock patients. Same with University of Utah, and actually University of Ottawa showed a similar response, not as dramatic necessarily, but the orange bar being their survival after initiation of the shock team in a similar patient population. So overall, a trend towards improvement in outcomes after starting these programs. I wanted to touch on the kind of protocol that exists in Ottawa. It's not to get into too many details, but essentially, it requires a full-on review in the CCU or the ICU, and either the senior resident, preferably the attending, reviewing the case before calling the shock team. And then essentially, it needs to have a pretty high suspicion for cardiogenic shock. A lot of the discussions that we actually had with your group early on in this, there was a discussion of should we be more inclusive of patients who have mixed shock, or do we really just focus on cardiogenic shock? And I think as a system, there should be a pretty high suspicion that it's at least primarily cardiogenic shock. But obviously there are certain cases where it'll be complex. So the ways of doing that can be either, with bedside echo parameters, or even invasive hemodynamics early in that patient's assessment, or maybe even just on history. But, I think most of the groups agree that the individual physicians that are managing that patient make the call and then activate the shock team. And then, then it's a collaborative effort from that point moving forward. So the heart failure team, the intensive care team, cardiac surgery, and interventional cardiology then make decisions together about the next course of treatment, and in what order. In Ottawa, they found improved 240-day survival in patients who were part of the shock team approach compared to their historical control. But no difference at the 30-day. So maybe their outcomes are a little bit more mild, but obviously it's not a perfect experiment either because the approaches have changed over time as well. There's also, important imbalances between these two groups historically. The control group had more ischemic cardiomyopathy, and there were just differences in the populations because obviously it wasn't a randomized study. Of course, the MCS use was higher in the patients taken care of by the shock team. And mostly, actually, even though this study is not the most recent, they were already using the Impella 5.0, which has become kind of the gold standard Impella. The 2.5 really just isn't used anymore, which was the type that was used in some of the original studies.
The 5's not used anymore either. It's a 5.5 now. So
it's a 5.5, exactly.
They're
So
on all these platforms.
yeah, so the CP, which is considered a 4.5 liters per minute, and then now the 5.5 is actually going to be, standard moving forward. So, but I think the most important thing about their outcomes in Ottawa is that it actually showed a Canadian experience and that it's feasible in the Ontario healthcare system. So you just touching on this again, the good thing too about the ongoing decision algorithms made in the shock team is really how to best assist the patients depending on their particular hemodynamic state, assessing them with invasive hemodynamics to decide what for example, if you have LV issues, then, you're going to have a high wedge pressure, you're going to have still high PAPI, which is essentially, like I said, it's a contractile assessment of the RV. So if you have residual good RV function, then you would go ahead with just an LV support device. If you have mostly RV failure, of course, that changes things. So, in Ottawa, they have the right-sided Impella and also the Protect Duo, which is another form of RV hemodynamic support. And of course, when bi-V failure is an issue, which is shown by poor contractility of the RV in addition to a shock state on the left side of the heart, then VA ECMO was considered the gold line MCS. So, with that approach in mind, they were able to really address the specific needs of that patient. UHN was not short behind in Toronto at developing a similar model. I think for the purpose of time, I don't think it's worth going through all the details, but essentially a very similar approach with slightly different cutoffs for the use of one MCS over the other. I think these are mostly academic decisions, and I think each center just needs to have a protocol that they sign up for.
Yeah, the only difference about the UHN protocol, which we've co-opted for ours as well, is a proviso for early renal replacement therapy for unloading for patients with severe congestion and poor response to a Lasix challenge. So that's not unique to us, but we definitely subscribe to that same philosophy of care.
So one of the things that, I want to be very careful about in discussing these models is that the shock team is not meant to tell individual physicians how to manage their patients. No one wants to do that. And I think, most of us who work as MRPs with sick patients, we're generally pretty good at what we do, everyone on this call included. But I think what it's meant to do is offer options and offer a collaborative environment where people can discuss their options and what would be best for this individual patient. So, a lot of these algorithms I just showed, they're very prescriptive of what should be done if you have a wedge over 15 and you have a right atrial pressure of over so and so. I think the value of it is not to be so prescriptive, but rather guiding in people making rational decisions about hemodynamics. So you'll see our model that we're proposing doesn't have as many strict criteria as those that were published from Ottawa and Toronto. Zach, do you want to go through this, or should I keep going? It's up to you.
I could talk about this. Maybe you can go over the protocol with the group. So I mean, our goals are really primarily to create a team. It's about the team-based care of these patients. It's not about the MCS-based management of these patients or the PA catheter-based management of these patients. Those are tools. They'll have their role, but it's about creating a team and a team of interested people to manage these patients in a group fashion. We wanted the protocol to be approachable for trainees and consultants alike who work in different contexts to use. The rollout will be to the ICUs, the CCU primarily at first, but it may roll out to other contexts like emergency departments, later. And so it needed to be something that was understandable to all and easily accessible. And then we do feel that the PA catheter has a central role in the management of many of these patients. And so, we have some suggestions around that. And then, of course, we wanted to help establish a culture of quality improvement, generally speaking, because there's certainly many things that we could all do better in these cases. And as an institution, I think that's important to track and discuss together.
So as it stands, this is our protocol. Essentially, I want to highlight a few things. I mentioned the inclusion criteria. So in the top left under step 1 there, we have a fairly broad inclusion criteria, which includes SCAI shock stage B or higher. Okay, so that's in the early development. So that could be as early as not even being necessarily hypoperfusing, but having an early state of development of the etiology of the shock. And they must have also hypotension and some sign of hypoperfusion. So it could be elevated liver enzymes, lactate. We avoided the use of creatinine because I think the baseline kind of renal function can get a little bit construed in that, and we wanted to keep it as broad as possible. Now, the exclusion criteria, the way we've set forth on this, generate a lot of discussion, but I think it's meant to create a program where we can actually see benefit of the shock team. And so people who are over 75 would be excluded from this approach. Obviously, it's not a hard rule, but generally speaking, someone who has advanced age in addition to this severe shock state have a very, very poor outcome right from the get-go. And the presence of cardiac arrest lasting more than 30 minutes, and other situations that really do threaten people's overall prospect of recovery. And, also, I want to focus too on who can call the shock team. As Zach mentioned, it can be rolled out later on. But for now, to keep the quality and the appropriateness high, we really are asking that a ICU or CCU attending be aware of the case, not necessarily be at the bedside, but definitely make the decision along with their team before activating the shock team. So that could be in the emergency room, but what we want to avoid is, it's nothing against emergency room physicians, but we really do want a very pragmatic and high level assessment prior to calling the shock teams, because this is calling people in addition to their already busy call schedules. And so, and when the call is made, then the call would be activated to a central system. Zach has actually done a lot of great work with our IT department in creating an MS Teams community for the shock team, where you can actually call into a video call, and say the fellow is at the bedside with the patient. You can actually patch in a confidential system on MS Teams and actually have a discussion with all the with all the attendings that are being called in, and even the fellow at the bedside. For example, you could be looking at POCUS images and so on to help make that discussion a little bit more interactive. So that's something that we've set up, and it just needs to be actualized through locating. And then the decision is made really about, how to act initially. So, obviously the interventional cardiologist would be activated if we think that this is an acute MI that's caused all this. But if it's not, they may not go to the cath lab, but rather, of course, they'll be treated in the CCU or the ICU, and then the decision of how to manage them will be done with the MRP and the rest of the shock team. As we have alluded to several times, we strongly encourage the insertion and use of the PA catheter to help identify the phenotype of cardiogenic shock, but also to make some informed decisions about the management. And as mentioned by Zach, also early recognition and consideration of renal replacement therapy is something to be discussed as well. So as you can see, this algorithm is less prescriptive than the previous ones we discussed. It's meant to be inclusive. It's meant to allow for a lot of discussion. But having said that, we want also to include what are the options for mechanical circulatory support here at LHSC. For LV failure, we do have the balloon pump, of course, that in certain situations is still effective. We should soon have the Impella, which is going to be a very amazing addition to our team. And then we have the CentraMag as well, which is the surgical option. If it's RV failure, we do have the Protect Duo that's inserted by our surgical team as it stands, and also the RVAD CentraMag system. And for biventricular failure, of course, VA ECMO is to be considered as well, and CentraMag as well. So the CentraMag is one of our most important tools right now. So the other thing to be assessed if on VA ECMO is if the left ventricle needs to be vented. And what we mean by that is, the ECMO provides a pretty high afterload, and in patients who already have a high SVRI or high afterload already, it actually worsens their condition rather than improving it. So sometimes we need to put in a second device that offloads the left ventricle. Sometimes it's just literally creating an ASD to help reduce the congestion. Sometimes it's actually putting in an Impella in the ventricle to help, empty the left ventricle as well to reduce the afterload. So, all of these can be considered as well with hemodynamic guidance. So I think, overall, I want to stop here and take some questions if there are any, but really, the key here is early on-site activation by the intensive care teams, using our app to really have a real-time discussion at the bedside. And we made it clear that with IT that this should be very compliant with privacy recommendations in the hospital. There was some big discussions had amongst the various groups the interventional one being one of them, about who gets activated. Like, is it the current person on call, or is it a separate shock person who's on call? And, I'd love to, obviously you guys work separately than or differently than how we do, but, it'd be interesting to see if you have any thoughts about how the ICU would manage that. But in our case, we kind of agreed from the interventional point of view and also the heart failure group that, it's whoever's on call should just be activated. And hopefully it's not that many patients a month, so it shouldn't be too onerous. There was some discussion also from the heart failure and transplant team, because they're so short-staffed, about adding their calls. As you know, they get all the transplant phone calls all night, in addition to rounding and stuff. And so there was some thought that maybe they can get involved only once we really have invasive hemodynamic information, as simple as a mixed venous gas or some kind of hemodynamic assessment. It could be as simple as POCUS, but they suggested that might be a way of relieving some of the extra burden on their workload. And I think just the key is, how do we manage who around on the shock patients from the point of view of the team? So happy to hear comments on that. So I'll stop there and take a pause for questions.
Thank you both very much. Yeah, I'll open up the floor for questions. If people want to put up their hand or type in the chat, that would be stellar, just so we can have some order here. I do have one question, maybe while people are marinating. Do you see a role? You mentioned POCUS at the end there, Dr. Ward, but do you see a role for point of care transesophageal echo? That's obviously part of the sort of workflow of the ICUs here. Is that considered part of the hemodynamic profiling, or is that going to be sort of a separate thought?
Yeah, it's a good question, because people have their preferences around how they will do their assessments. And so, we obviously pushed for PA catheters, but there's a lot of data coming out of the POCUS world that having real-time echo data is very informative in terms of assessing current hemodynamic states. My reservation around the actual TEE is that it's not uninvasive, and repeated insertion of a probe is not without risk. And so if you can get the same with a central line that stays within the circulation and doesn't need to be adjusted or anything, I wonder if that would be simpler and a little bit more complete in the assessment. But I think it's important to be inclusive, that if the team is thinking that that's the method that they feel is best for that particular patient, it's their skill set, then we don't want to discourage people from using something that's going to be informative for them. Having said that, as you can see, most of the shock teams use fairly robust markers of hemodynamics that are obtained from the PA catheters. So we'd probably still be striving towards that form in addition to whatever's already being done.
Maybe I could just add a quick comment to that as well, because I agree. I mean, nobody's suggesting that a shock team should not use echo. We need echo. Of course, it's a crucial component of the assessment. It provides a ton of information. It's very important to helping identify the phenotype. I think, though, that when we're discussing the sickest of the sick patients, the ones that we're all struggle a little bit more with, everybody knows how to manage a SCAI shock who gets better on an inotrope. But when we're talking about the sickest of the sick, what is their candidacy for MCS? If they are a candidate, what is the appropriate strategy, configuration, etc.? The additional details of invasive hemodynamics are absolutely crucial and necessary over and above what echo provides. But if you're in the initial phase of resuscitation and clinically they're a SCAI and you want to phenotype them by echo and start initial management, that's very appropriate. So it's a matter of just what information you're getting and what type of patient you have.
Thank you. Dr. Bosman?
Thanks. So I'm really excited about this initiative. I think it's fantastic. And I really appreciate the philosophy that it's access to a discussion with experts, and it's a discussion between the MRP and this team. I really commend that philosophy. Just a question about the logistics. Do you mind to go back to the slide that showed the LHSC protocol?
Sure.
So on this, so the code shock initiates a discussion among CCU, ICU, heart failure, interventional cardiology, cardiac surgery. So what I was just wondering was, is it all interventional cardiologists and anybody who's, are all interventional cardiologists part of this and all cardiac surgeons part of this? Or so that whoever's on call that day, it is those people, or are there any people that have kind of opted out or say, this isn't my thing, or I don't put in Impellas, or is it a specific group within those categories?
Yeah, so that was one of our first questions. From an interventional cardiology point of view, I can tell you everyone has agreed to be part of the discussion. So whoever is on call that night can be called to discuss. The CVT group has been a little bit sluggish in individually responding. Having said that, their leader, Dr. Chu, has advised that there's no reason that the group should not be all involved because these are decisions that involve all of them when they are on call. So I don't have a formal yes from every individual like I did in the interventional group, but the program itself is supportive to move forward as it stands with whoever's on call being called. Now,
Okay.
we often talk about the pros and cons because, if, Stuart Smith is on CCU, obviously his approach to heart failure is going to be much different than mine, for example. And I think, the power of the group is if you have 5 people on a call, even though one person may be not super keen to do something, invasive with circulatory support, I think it's about the consensus and the discussion. And so, there's always going to be a few people on that phone call that really have, say, contemporary, up-to-date approaches towards managing shock. So the power is in a number, so to speak.
Dr. Cameron, can I have a part B?
Of course.
So you partly answered what I was about to ask, Michael. So if the person on for CCU is different than the heart failure person, then the interventional cardiologist, we could have 3 cardiologists on the phone giving different opinions. Okay, and I think that's great. Yeah, I think you touched on that. I think some of my frustration in the past has been you call one person and you just get a hard no, and you knew you were going to get a no before you even picked up the phone for certain, questions that you're about to ask. So I think a discussion is good. And I think, including the naysayers with the pro people or the aggressive people is a good option. I wouldn't want this to be a call to someone who's going to be like, before you've even picked up the phone, they were looking for a reason to say no.
No, exactly. And I think, this is why it's taken a couple of years to roll this out, because getting the buy-in from everyone is key to its success. So circulating the protocol, allowing everyone to feedback and adjust, the protocol itself, but also just to get used to the notion of it, is something that is very important.
Yeah, we're very hopeful that decision by consensus will end up with the best overall decisions, and that we can all benefit from learning from one another's perspectives as we interact more often and in a more structured way.
And I think there's so much value in even just having people who are interested in cardiogenic shock kind of in a way leading the team, even though they may not be on call every night. They, will be doing QI rounds, we'll be discussing difficult cases, we'll have research projects. There's already a student that's approached me about tracking our data to do similar, outcomes assessment than Ottawa did. So, all of that is going to increase our confidence and also, I think, our proper decision making for these sick patients moving forward.
Yeah, we didn't present it actually, but there is like a formal kind of language around a steering committee and each group being represented within that, one person, one vote. And so it is meant to be kind of organized as well at a higher level beyond just the haphazard model of who's on call, let's get on the phone.
Excellent. Any other questions? I have one more. So we've got another minute left. Just that the run part here, activate code shock. Does this mean if you get that pager that goes off and you're on call that you then log into the team's multidisciplinary call, or what's the workflow you're imagining?
I'll let Zach take that one.
Thanks. So Beep will beep you. It'll send you a URL on Beep. So that'll come to your phone as usual. And then that URL should be clickable or copy pastable to your browser, and it'll bring you directly into a browser-based Teams call where you are HIPAA compliant and you have audiovisual. So I'm at the bedside, I'm showing you the echo and the vitals in real time or whatever other finding of note. And it's all in the moment. So it should be really easy to do. We've tested it. Like Beep sends you the link, you click the link, boom, you're in. So you know, you could be really not tech savvy and not awake, and it still should work great.
Yeah, that sounds awesome. I hope you're not implying I'm not tech savvy. That's a pretty big shot you just took there. I guess last question is in the text there. Who's the final decision regarding the next steps of management and MCS?
Sorry, can you repeat that question, Paul?
Pardon me. The last question is, who has the final decision with regards to the next steps of management / MCS?
Well, I mean, I think, you know, in the ideal discussion, it should be a consensus decision. Now, you know, for example, no one's going to force the surgeon to do a surgery, right? So it's still the surgeon has to make the decision about opening the OR and doing the procedure that he or she may feel is safe or unsafe, right? So I think there still has to be autonomy from the individual who's taking on that responsibility to make a final yes or no decision. But ideally, the decisions around management are done by the on-call team acutely, and then by the daytime rounding team in consultation with the MRP. So it should be as consensus as possible. And that's to avoid what Dr. Bosma was asking about, just having a hard no from someone, right? That sometimes is less helpful than should be. So, I think, but we can't force anyone to do anything. So the last decision has to be the proceduralist, of course.
Excellent. Thank you. With that, I might draw the formal session here to a close. If people have questions and if our presenters are able to stay afterwards, we greatly appreciate it. But thank you to Drs. Ford and Singer for an excellent overview of multiple years of work. And yeah, I'm looking forward to getting the first URL Beep if I can figure it out. So thank you both. And thank you to everybody on the call. I will record this and post this on the Critical Care London YouTube.